My name is Giuseppe Tarantini and I work as interventional cardiologist at the University of Padua. And I'm really thrilled to kick off this session that deal about complexity in the treatment of patient in shock. We know that we have had a recent release on New England Journal of Medicine, so many things to discuss. And we will do mainly with the help of this, very well-known speaker and world-class, let's say expert in this field. We have Aleida Cheffo, Norman Magner, and Masha Yeki, that actually, we will discuss with them all the different aspects. Having said that, the only recommendation is to try to make the most of this opportunity to learn and share. And actually, these are the main session objective of today. What I wanna have is to delve deeper into analyzing and discussing the findings of danger shock randomized trial. I think it's very important to read, the lines and between the lines, and to understand all the different folding of this trial. We'll explore the latest evidence that is emerging in ACS field, like the horizon. Then we will implement, this is the most important part of the meeting, we will implement the evidence-based practice by discussing the peri-procedural planning, execution, drug administration, weaning strategy to optimize the outcome in acute myocardial infarction complicated by cardiogenic shock. So without any further ado, I would like to encourage just to post questions because we have there the laptop we can read and share with the other people in the audience. And I would like to invite the first speaker on the platform, that is Aleida Cheffo. What's new inside? Does danger shock give for treating patient in cardiogenic shock? What is next, Aleida?
So these are my conflict of interest. Let's start with the study design of danger shock, because it's very important to take into perspective the result of the study considering the study design. This was, first of all, an investigator-driven study, started in Denmark, then extended in Germany, and then extended also in UK. And the time of enrollment was quite long, 10 years. And they did enroll patients with ST elevation MI, less than 36 hours. I mean, there was importance of time of onset to the randomization. So the inclusion of hypotension and hypoperfusion, LVF less than 45%, randomization when the shock was diagnosed, and they were randomized 360 to Impella CP versus control arm. They were excluded from the trial the patient who had an out-of-hospital cardiac arrest, comatose, right ventricular failure, and mechanical complication. And the primary endpoint, and this is a difference from other trial, was all cause of mortality at 180 days. So it's not in-hospital mortality, it's not 30-day mortality, but it is at 180 days. Patient characteristics. The median age of the patient were 67, 79% were male, median lactate was 4.5, majority of the patient had as a culprit LAD or left main, but there was a 72% that were multivessel disease. Median 4 hours from onset of STEMI symptom to randomization, 84% randomized in the CALAB, median LVF 25%. Most of the patients were in SCAI class C, 55%, but there were 45% in D or E, and median systolic BP 82. And this is the primary and the secondary endpoint. As you all know, there was a reduction in the primary endpoint of all-cause mortality of 180 days in favor of the usage of Impella. This was an absolute reduction of 13%. The number needed to treat is 8. Regarding, indeed, the secondary endpoint, that was very much discussed, and we will go into details in the next slides. It's also very important, I think, since I think there is a lot of confusion among trials, among devices, to see this in perspective. So in these slides, it is shown in perspective the results from the danger shock and ECLS shock. As you know, there was a neutral trial with ECLS shock, 30-day mortality, no difference, and there was indeed the benefit in the danger shock, completely different inclusion criteria. We will go in that at 180 days. But let's see comparison one-to-one. As we said, majority in danger shock were class C. Indeed, in ECLS, there was a mixture. They had class C, Sky C, that most probably is not the patient that you are using ECMO in your everyday practice, at least we are not. And then there was D and E, like the majority of the patient. Another important point of distinction among the two trials, in ECLS indeed were included patients that had out-of-hospital cardiac arrest. There were 77% in the trial of ECLS shock that were resuscitated before randomization, and the median time was 20 minutes, which is a really long time for this patient. Indeed, the difference is that, as we know, there was an upfront implantation in danger shock. Actually, this was also aimed in ECLS, but the majority of the patients did implant the ECMO during or after the procedure, and resuscitation before randomization 21%, intubation 19%. So it is a completely different population. And again, when the Impella was implanted in majority in danger, as compared indeed with a minority before revascularization in ECLS, we have also 9% that actually in ECLS did not receive the ECMO. And most of the patients in ECLS indeed had ECMO implanted during or after revascularization. And despite the fact it was asked to the operator to use mechanical unloading, only 5% in ECMO group in the ECLS did add a mechanical unloading. And we do know the difference physiopathologically of the two devices and the increase in afterload with the ECMO. And how can this be quite warning if you don't do unloading when you implant an ECMO on? So what new insight does danger shock give? Let's go in, we said were the inclusion criteria, some red flag in the sense that we need more information. There was also this discussion on why 79% of the patients are men. Where are the women? And clearly we need to do better on that. Most probably this was a STEMI, ischemic, complicated with cardiogenic shock. As we know from registry, most of women presenting with cardiogenic shock indeed have non-ST elevation MI, or they can have non-obstructive coronary artery disease as cause of STEMI. So most probably because of the inclusion criteria and some delay of diagnosis, because women have sometimes different symptoms, this is the main reason why in this trial they were not captured. So maybe trial more specifically with inclusion for women population. Then the median time from onset to randomization, that was very good. Actually, we know there is a golden hour to treat shock, and in this trial they reached the golden hour because, as we said, it's 4.8 and 3.8 in the Impella group that get the randomization from the onset of symptoms. So we are in the golden hours. Regarding the randomization occurred before PCI microaxial flow pump place, and again, very high percentage of patients did what is advised to do, so implant Impella before performing primary PCI. The endpoint, clearly it was met. There is some discussion why the control group has such an high mortality, because this is the highest mortality in a control group of cardiogenic shock, and we can maybe further speculate later on what can be the potential cause of that. And so that's why you see this orange. And clearly there is the warning of the composite safety endpoint, because there was a 24% of composite safety endpoint, and these were mostly driven by moderate or severe bleeding. So clearly, we have to take into account the long time of randomization, and this is a point where we have to do better, clearly. So what may have influenced the rate of adverse event? Clearly, these are speculation. Long time of enrollment. Clearly, we start in 2013, and everybody learned by practice how really to manage large bone access and what you have to do to really optimize the access management. Learning curve, there was a learning curve. I mean, you see most of the coronary operators are now radial. They had to relearn how to puncture the femoral artery. So it's a very important point in all educational programs starting with these devices to know how to manage access. So you have to do puncture, ultrasound guided, you have to do preclosure, you have to be very careful. And access site management is the key. And then the issues of the need for replacement, kidney replacement therapy, and this is speculation if clearly hemolysis and anemia could have played a role on that. And again, this is because of the management of the device and the learning curve. What is the next? Is short all-cause mortality a good endpoint? Clearly, they went to 180 days. Do we have to stick to mortality endpoint? And I think that's a very good point, or we should move to something else. What is next? Again, how should we investigate optimal management for cardiogenic shock? Do we think that only one device can be the solution in such a complicated scenario? First, it's hub and spoke model. As we were very good in building up STEMI network, the next level is to build up shock network. I mean, we are doing something quite pilot in my region that was done by our region and the government, and we do have at the present time 2 centers managing as shock center, and we are doing a very nice study with the Italian Society of Interventional Cardiology addressing the importance of do education on our spoke, because the patient has to be recognized promptly also by the spoke center, and we have to know when to transfer to cardiogenic shock center. So network and how to educate spoke and how to refer to shock center, identification of shock center is the key. Second, multidisciplinary management. Cardiogenic shock is a very complicated disease and cannot be handled only by one specialist. When you set up a cardiogenic shock center, you need to have a team. The team means your intensive unit care specialist, anesthesiologist, if you have cardiac anesthesiology taking care of that. Also, nurses that are prepared to take care about this device in interventional cardiology. So everybody has to be on board, on call, and when the patient, there is the suspect of cardiogenic shock by ischemic, everybody has to evaluate the patient and to follow the patient through all the clinical course of the patient. That's the key for the success of any program. Clearly, appropriate patient selection and stratification. This is very important, and again, there are a lot of delay or prompt recognition of the disease, and we cannot do that because, as we already said, there is golden hours. I mean, time is myocardial muscle, not only for primary PCI, but especially for recovery of left ventricular ejection fraction. And last but not last, optimal combination of medical therapy and MCS. Again, this is a continuum of patient, and it's not only one device, it's a strategy that we have to take in place in order to reduce mortality. And this is my last slide as president of EuroPCR. Clearly, there is an open call now for all EuroPCR members if you're not registered. And we are building up our committee for 24 and 26, and you can just scan this and apply and be part of the next term of EuroPCR. Thanks for your attention.
Thank you. So by the program, the discussion is postponed at the end of the 2 further presentation. So actually, thank you, Alaide, for the bright presentation. I would like to invite to the podium normal. But anyway, the only comment is that out of all the trials that has tested the MCS and cardiogenic shock, this is one of a kind and the landmark trial, because this is the first one that showed us that it's possible to drop down the mortality in cardiogenic shock. But I will get back to this. Next speaker, please.
Yeah, Giuseppe, thank you very much for the introduction. I move now a bit away from the classical cardiogenic shock field because I have to talk about the new studies on the horizon, STEMI-DTU and PROTECT-4. These are my conflicts. So we have seen danger shock now, and there are upcoming trials like RECOVER-4 or Unload ECMO, which really deal with the patients having a cardiogenic shock according to Sky Class C, D, or E. And the intent of the use of a microaxial flow pump in this setting is clearly a treatment strategy to treat cardiogenic shock. What I want to talk about now are two trials which are a little bit more located in the patient cohort being at risk, so at Sky A. So this relates to PROTECT-4, and this also relates to the trial STEMI-DTU. And the main intention to use a microaxial flow pump in such a population cohort is more a preventive nature, to facilitate complete and high-quality PCI, to avoid hemodynamic decompensation and cardiac arrest, and maybe in the setting of the non-shock STEMI to prevent heart failure development. So what is the rationale, what is the clinical experience, and what are some data related to high-risk PCI? So maybe if you have this patient in front of you, you have a severe triple vessel disease with a high-grade stenosis of proximal RCA and a complex left main bifurcation which is heavily calcified, and you have reduced ejection fraction, and you are planning to do all those complex treatments on the patients where there is a specific risk for hemodynamic decompensation. What would be your day without? Yeah, so if you see something like this, you lose pulsatility and you have laminar flow with the impeller in place, then you are quite reassured that you have done the right thing. But the question remains, who are those patients who are really in need for hemodynamic support during an intervention? And to be honest, the database is still very small. So we just have evidence from one randomized controlled trial, which has been undertaken more than 10 years back, and this was PROTECT-2. You might know that these have been 450 patients requiring a high-risk PCI, and they underwent that with an Impella 2.5 compared to the control group which used an IABP. And the primary endpoint was set at 30 days, and indeed, this trial was negative because the primary endpoint was not reached. But having exploratory analysis, which was pre-specified, looking up to 90 days, there was a divergence of the Kaplan-Meier curves for the MACE endpoints favoring the microaxial flow pump group. And we might ask and discuss later what might be some reasons for that. However, with a newer device and with a better patient selection, as we see those patients included in the PROTECT-3 registry and compare those ones who would have been eligible for inclusion in the PROTECT-2 trial to the traditional PROTECT-2 Impella patients, we can see that with the advancement of technology, with a learning curve, with a better understanding how to revascularize those patients, in hospital complications, as shown in the lower bar here, came down in the more contemporary cohort. This includes bleeding, vascular complications. Adaida already mentioned that there might have been a learning curve over time. There were less hypertensive phases during support. There was a lower rate of CPR, ventricular arrhythmia, and this resulted into a reduction of an early MACE endpoint. Okay. And again, as defined in the PROTECT-2 trial, also in the midterm, over the course of 9 months, a better outcome in the more contemporary cohort regarding MACE was observed. So, however, the database is low, and that's why we are looking for the PROTECT-4 trial, which is a large randomized controlled trial with patients having ejection fraction 40 or lower, and they present with chronic coronary syndrome, with an end STEMI, and with a STEMI in certain situations. I don't want to elaborate so much on that. Importantly, all the patients, because they are typically surgically candidates, have to be discussed in the heart team. So after heart team decision, those patients who are decided to go for complex PCI are eligible and can be enrolled. This will enrich the population with a high-risk patient cohort, because we know that surgical turndowns are, for example, a population that has a very high risk for MACE endpoints during follow-up. 1,252 patients will be enrolled, and as yesterday, 957 patients have been already included. This means 76% of the planned cohort. And they are randomized to the PCI plus Impella CP versus PCI plus minus intra-aortic balloon pump. Why plus minus? This is related to the fact that this is a transatlantic trial, and the US typically has a higher use of IABP in the setting of high-risk PCI compared to the European centers. But please read here, the randomization is stratified by the intended IABP use, which is important to keep the groups consistent. The study is also accompanied by a registry of those patients fulfilling inclusion, but having one or more exclusion criteria, and this will inform us about the cohort of patients also treated in the centers during the course of the randomized controlled trial. The primary endpoint is not an acute endpoint, it's a long-term endpoint consisting of all-cause death, stroke, durable LVAD implant or heart transplantation, myocardial infarction or hospitalization for cardiovascular causes at 3 years of follow-up, with the last patient in having at least 1 year of follow-up. With the pace we have right now, we expect to finish in Q1 25, and then we have to wait 1 more year until Q1 26, so maybe we can expect the data in 26. So the protocol of the trial is very strict and is very controlled that the investigators follow, because we have heard about complications, and in particular, if we do it as a preventive measure, we want to avoid every complication associated with the device. This means prevention of bleeding, so it's mandatory to use ultrasound and angiography confirmed access. We use state-of-the-art PCI. I think Campus will elaborate on this. And this is not only a trial for the interventionalists, it's a trial really for the heart failure doctors, for the nephrologists, for the imaging guys, so because there are right heart cath sub-study, viability, renal sub-study, and of course with an endpoint ending at 3 years, it's very important to have a very good GDMT board, because medication and heart failure associated devices will have an impact on the outcome of those patients. So having that said, I want to go to the other patient population I have to discuss. This is a non-cardiogenic shock STEMI cohort, and we know most of our STEMI patients now have a very well outcome with regard to survival, so mortality is low. However, those patients might develop heart failure. And there's this one study out examining STEMI patients with a cardiac magnetic resonance tomography, showing that above 11% of the patients develop adverse remodeling. This was defined in this study by an increase of the end systolic and end diastolic volume by at least 12% or more. This is a so-called group 4. And you can see if you have adverse LV remodeling after STEMI, then your prognosis is poor with regard to a MACE endpoint over the time period of 5 years. Unloading might be a concept to reduce adverse remodeling, and there are many data out coming from the preclinical phases. For example, this trial published in 2018, done in a pig model with an ischemia reperfusion model. And you can see that there have been different groups, and the one I want to highlight on is the one who had 30 minutes of unloading, and after that a reperfusion, the so-called group 3. And you can see that infarct size in this animals has been significantly lower compared to those having reperfusion alone, having just 15 minutes of unloading, or having reperfusion first and unloading afterwards. This might be related to molecular mechanisms, including cell death, reduced infarct size, and therefore a lower scar burden afterwards. And this is not a new concept. More than 40 years of LV unloading have been performed in preclinical models. You can see those trials here, and the question, was there a reduction in infarct size? And you can see in most of those preclinical trials a reduction has been observed. But the question remains, can this be translated into a human disease model? Because those animals are typically healthy animals having no atherosclerotic burden. So the question is really, how does it translate into humans with a disease? And there was a pilot trial for an unloading strategy, you might be aware, published by Navin Kapoor in 2019, enrolling 50 patients. All of them received a microaxial flow pump, and then there was a pump which had an unloading for 30 minutes compared to starting the impeller and starting directly with the reperfusion therapy. And what you can see that there is in the overall cohort a numerically reduction in infarct size, but the more severe the myocardial infarction is, as indicated by the STS sum score, the higher is the impact of the unloading on the infarct size. And this builds the foundation for the STEMI DTU pivotal trial, which is now underway. Patients aged 18 to 85 years with the first myocardial anterior infarction can be included. They have to present within 1 to 6 hours of symptom onset, and they are indicated for PCI. Those patients are characterized by an LV cram, by an angiography of the access site, and an LV-EDP measurement, and then an eligibility committee, which is online, confirms the potential eligibility for inclusion. And the patients are randomized to an Impella CP, unloading for 30 minutes without a coronary angiography during that time, then followed by PCI, and support after PCI about 4 to 6 hours, and then the subject returns to the cath lab and the impeller is explanted. And the control group receives standard of care guideline-directed therapy with a coronary angiogram and a PCI. And the primary endpoint is assessed in the CMR 3 to 5 days after the event. And this is something this is a primary endpoint, so infarct size normalized to left ventricular mass. But there are key secondary endpoints, and the trial is powered to assess those clinical endpoints too. And that's important not only to have an imaging endpoint, but also a clinical endpoint. So in summary, microaxial flow pump in high-risk PCI and STEMI without cardiogenic shock is intended to reduce procedural complications, to improve early outcomes, and to enable optimal lesion preparation, stent implantation, and maybe to facilitate complete revasc, which hopefully will lead to improved later outcomes with a reduction in MACE, heart failure development, arrhythmias, hospitalization, and quality of life. Due to the preventive nature, I think safety is of utmost importance in those situations. We have to avoid bleedings, we have to avoid vascular complications, and we have to avoid stroke. And upcoming randomized controlled trials will hopefully inform us about the true impact of the microaxial flow pump in those clinically relevant settings. Thank you very much.
Thank you. We'll move forward to the last speaker. This is the third point of the session objective, that is evidence in practice, clinical implication, Cambis.
Thanks, Giuseppe. So basically, what determines mortality in cardiogenic shock, right? One really important predictor is still the contact to the hospital. So when the patient are in severe shock and they are somewhere out in the hospital for 3 hours or 4, mortality rate is quite high. So that's very important. Which revascularization strategy should we use in cardiogenic shock? Carpal lesion. It's also clear. How is it in STEMI? Well, in STEMI, complete revasc makes sense in terms of stage procedure. Mortality rates are better when you do a complete revasc. But what's with the remaining patient in shock, which still have residual higher syntax score? Well, those are also at risk. So we have to do something after a carpal lesion PCI. And there the question is, how can we treat those patients safe, which have almost a severe LV function, severe impaired LV function? Maybe you might be interested in this paper, which is almost the use of mechanical circulatory support in elective high-risk percutaneous PCI. We are concentrating on shock today, and the question is still regarding the access site, and that's very important. Whenever you are able to do so, go radial. But when it comes up to mechanical support, you need the femoral nowadays still, right? And that means more complication rates, higher mortality, more blood transfusion. And that's the downside when you see things like that, when you have an acute setting where you need to put mechanical support inside and you might run in troubles. So whenever you are able to have a little bit of time still left, try to make a CT scan and try to find a good access site to make a safe procedure for the patient. So when we look at the data, Lydia already mentioned it regarding the cardiogenic shock, and ECLS shock trial is a completely different subset of patient, right? We will go to the discussion. But if you have 80% of patients already dead while going into the randomization, maybe a single device is not the answer. And we know that left and ventricular unloading in patients which are already in the hospital and have ECMO running might be beneficial. So LV venting with Impella seems to be a really good option when you not do it too late. So you have to do it in the first 2 hours, and data are quite ensuring that it makes sense. So now we have the first trial out that a device can help us in cardiogenic shock, which is fantastic for us all, right? But we have to know how to use it properly. Nevertheless, still we have a lot of answers remaining. Basically, what I want to tell you is the management is not so simple. Probably the most important information on this slide is that you go to the AHA statement of circulation, and if you're more interested, go through that. Because you will find patient at high risk, like Norman explained to you in SKY AB, then you will find a shock patient, you find a cardiac arrest patient. All of them needs a different treatment. The same here. It's a big slide, a very nice paper with a detailed algorithm of temperature mechanical support that you really understand what you have to do. Do you have an LV failure, like here? Well, it's good to go with Impella. Yeah? Do you have a cardiopulmonary failure? You might need VA ECMO. You might need Impella on top for LV unloading. And the paper gives you also a little bit of answer how and when to wean. Nevertheless, coming back to daily business. 57-year-old male, ejection fraction 45, unstable angina, nothing else. Diagnostic angio, you see a strange left main. 2 minutes later, resuscitation, okay? And this is where the Impella comes in place. We could put the Impella, no intubation, free shocks, right? Patient was going with Impella on the ward, but, and that's also Impella, bleeding, retroperitoneal bleeding, right? So, that's something which can occur when you are inserting this device urgently under stress, but it saved the life of the patient. The patient could be discharged after 10 days, but we had to do a surgical revascularization. Another important question is basically the randomization bias, right? This lady would have been dead several years ago. RCA is occluded. She came in Sky B shock, right? Subtotal left main, a lot of calcification. You can see here, Impella in. She's stable. She's talking to us. We have time. We rotoplate her left main. We shockwave her, right? And at the end, we can fix that whole scenario here with, we have the time to go through that and do some culotte standing, and we also have the right, so we finished with a short attempt on the RCA, and she's happy. Okay, she's 82 years old. I get a postcard, and she could be discharged 3 days afterwards. That's fantastic, right? But it's possible with new technology, Impella, shockwave, things like that, right? Then we have another subgroup of patients where we still don't have the answer. What's with patient? Basically with severe valve diseases and additional coronary artery disease. This patient came in shock. They compensated. Oliguria, the mean arterial pressure is down. He cannot breathe anymore. We had time for the CT, valve-in-valve implantation, and then, okay, this is as it is, right? And then you have already the sheet inside, and you still see that there is a high-risk PCI, because we have seen already that the left main is subtotal or almost very calcified in the CT scan. So it's fantastic, because we don't have any additional risk here, because the sheet is already in. So Impella in, revascularize the coronaries on top, right? And I was happy that I did that, basically, because no flow on the LED, complex procedure, everything went well, patient's doing good. So we don't have any trials for that, but we have the patient for that. So we have to treat them, right? The question is still when to wean these devices. And basically, when I prepared the talk, this took me more time to read that slide than the whole talk. So yeah, you cannot get it, okay? That's the point here. But you can just take the circulation paper, and you know that when you wean the device, there's some certain interesting parameters where very intelligent people are thinking about that. It's hemodynamics, it's physical examination, it's echocardiography, and then you have weaning protocols. And then you can decide between, here you have the Impella, the rapid weaning, which we do in the cath lab for protected PCI, or standard weaning frequent, which is every 2 to 4 hours, reduce your level and makes blood gases, check your hemodynamics, and then you can wean the device successfully. So summarizing, mechanical support with Impella showed a reduction of mortality in patients undergoing acute myocardial infarction with cardiogenic shock in the danger shock trial. Fantastic. There are positive signals for LV venting with Impella in patients with cardiogenic shock under ECMO. Whenever possible, do a pre-planning with CT for the access site. Invest that half an hour if it's possible. Consider dedicated weaning protocols before explanting the device in patients, especially with cardiogenic shock. Thank you very much.
Thank you, Cambis, for this bright presentation. Actually, we have a short time of discussion, so this was the reason why I talked to her what's next, just to see if we have some minutes more. It seems that we have 5 minutes more. So let's get started. I have a question posted by the audience, anonymous, is how should we use left ventricular end diastolic pressure in making a decision regarding the support during high-risk PCI? You want to answer to this, and then we can... Okay.
Basically, it was already also in my slide, but I had no time. So, as you know, that radial approach is safe in cardiogenic shock. And if you have a patient with impaired LV function or a beginning shock, you can measure the LVADP. If the LVADP is high, let's go going more than 25, I think you should consider hemodynamic support in this subset.
Okay, trying to answer also to the high-risk PCI besides the shock condition, actually what I used to do, I don't know if it's reasonable for you, what is important is to look at the blood pressure. If the blood pressure is 90, 95, 110, 100, and actually you start vasopressor, you won't see any change in the pressure. This means that the cardiac power is very low. When you have a left ventricular diastolic pressure that is 40, 90 minus 40 means 50 millimeter of mercury. You are outside the autoregulation curve of the coronary. So you need to have something there to avoid, to anticipate any hemodynamic decay that might be likely, because based on your procedure, it's likely that you have a kind of hemodynamic decay. So you need to prevent it. You cannot go in a bailout fashion. This is the reason why I prefer to go preventive as you did. Aleida, you have any? Probably one question for Aleida. How do you explain? Because when I go to the meeting, after the danger shock, they ask me, could you explain to me? I have my own idea that I will present later in my conclusion. But actually, why? How can we explain, Aleida, that in cardiogenic shock we can see a progressive growth of the benefit in the Impella arm compared to conservative arm? I think it's something that everybody wants to need or to hear some, answer.
I mean, because theoretically, what you are doing is going to act on the unloading of the left ventricle. So clearly, if this patient coming with that 20% at the end of the procedure, I mean, we have our series, everybody, at 50%, clearly this is impacting. You have a reduction of heart failure of this patient. That's why most probably it's not only about mortality, but the trial should go in a composite endpoint, take into account the hospitalization for heart failure, recovery of LVF, because this is why the mortality is going to benefit longer term, because you have recovery of LVF.
Yeah, this is a good point, and I think this is the reason why the Protect 4 was designed to have a follow-up. The primary endpoint is between 1 and 3 years, because the concept is the protective effects that you will see at the longer stage, at the second window. So we have two windows of opportunity, the acute phase in the hospital, but actually the benefit that you can get very early you can see also during the second window, opportunities more than 1 year or 3 years. I don't know, you want to have some comments or other comments?
I mean, still, I mentioned that point with the randomization problem that we have, right? So even basically, let's say the trial fails, right? Still, I have some concerns treating those patients without any parachute, even if I have no evidence. So that's because what should you do in those kind? I've seen those patients, right, dying, and they are here, right? So that's always my problem that I have on randomized trials when it comes to the end stage of any disease, especially cardiogenic disease, like we have seen at the ECLS shock trial, which patient are randomized 80% already dead outside, right? So now, honestly, would you have randomized such kind of lady which is coming in? So you cannot do, but those are the patients basically which are creating events when you do it not in the Impella arm, but is it ethical?
I think Campus, yes, this is a very good question. So cherry picking might be a problem in all randomized trials, and in particular in the Protect 4 trial. Who wants and who has time, I invite to come to the training village at 3 p.m. So I have 2 cases which we have randomized, and the one who is in the control group is nearly the same which you have shown. And I think we did so, but I'm also a bit afraid of that there is selection bias. But within the trial, there is a strict control how in the centers the impellers are used and in which cases, and hopefully we can show that there is no cherry picking.
And therefore we need the registries, right?
Yes.
We need the
registries.
registries.
Yes, but unfortunately only randomized clinical trial can change class of recommendation. So you need brave investigator as the one of danger shock, and I have all my respect, because honestly for me it would be almost impossible to randomize, but they did it. They did a tremendous work, and this will help us to get better recommendation, upscale of recommendation.
Okay, thank you. I think we need to go for session evaluation in Killarney. It's a pity to not have longer time to discuss. I'll try to not confuse the things more than they are sometimes. So this is the overarching principle. MCS is indicated when hypoperfusion is identified. So that means that as early as possible, because the best way to reduce the mortality in cardiogenic shock is to prevent the transition from the reversible to the irreversible phase. I'm referring to the metabolic parts of the cardiogenic shock. So SCAI C&D is mostly like what we have seen with a danger shock. So before PCI, so it means in danger shock, more than 50% of the patients will receive the MCS, the Impella system, before PCI, some other after the PCI. But actually, we don't have this trigger point of intervention with the ECLS trial. We don't know exactly when the ECMO was placed in. I try also to contact, to reach out. The first order, it didn't answer to this point. According to the phenotypes, we need to try to select the best MCS to use in this patient. Might be right, might be left. So there is one size does not fit all, and actually this is something to keep in mind. What about, this is a busy slide, but I will go fast forward. All is about pre-specified protocol, early detection. The early diagnosis is important, phenotypic cluster, MCS feasibility, then you go for early intervention. So it's not just door to balloon. What is important also is door to unloading. And in cardiogenic shock, in situation where the end-diastolic pressure is very high, the door to unloading is much more important than the door to balloon. So actually, because unloading the ventricle, you can increase the perfusion pressure with the same level of mean aortic pressure, and you can improve, the perfusion of this heart. Then you have to have a short team, spoken up model, networking, and standardized protocol. All is about standardized protocol in cardiogenic shock. You cannot invent for every case, a different protocol, a different, way to treat these patients. And finally, timely recognition of modifiers that are, cardiac arrest, we have already seen, shock severity, organ failure, hemodialysis, and so forth. But for me, the most important part of this story is my view that I would like to share with you about the comparison between the danger shock and the ECLS shock. When you look at the baseline characteristics, these are with the red marker, the main difference in the baseline characteristics. So the E class is 32 against 15, lactate admission is 7 against 5, resuscitation is 21 against 77, and actually the MCS initiation before PCI is 50 against 20%. But the point is, and this is the real crucial point, we look at these baseline characteristics and we think that we are dealing with total different population. But the real question is to you, is it true? So this difference, how turns out in terms of the real mortality in the two trials? And I'll try to convince you that the baseline population is not too much different between the two populations, and thus we have probably a direct effect of the type of MCS that you select. And I'll try to convince you about that. We don't have the data in the danger shock at 30 days, but I was able to extract by the Kaplan-Meier by means of this methodology that you can see here the paper. When you compare the 30 days, for me what is important is to evaluate the control arm mortality rate. It is pretty much the same. 47 against 49, the difference is 2%. That means that if we think that the risk profile of the patient is different, we are wrong, because the mortality rate can be used as a proxy of the mortality risk of the two populations. So when the mortality is similar, we can discuss whatever we want, but the population are totally different. What is different between these two trials is the effect of Impella against ECLS, and the difference, the size effect is 8.2%. So one may argue, let's say, okay, why we don't see the effect at 30 days? I think this is the most important point that you want to, when you get out of this room. Why at 30 days I don't see the benefit, I see the benefit at 6 months? I think this is the most important question. But actually, I'm not surprised, because the difference is 7%. It is huge. Because when you make the difference between thrombolysis and primary PCI, is only 2%. And we have class 1 indication for primary PCI. In this case, we have 7%. That means a relative risk reduction of about more than 15%. And this means that actually we need, with the time, we have an increase in the size effect of 13%. And actually, we would have needed 1,200 patients to demonstrate that is significant at 30 days. But again, and I will conclude with this statement, in cardiogenic shock trial, all of us use primary PCI and early revascularization, and at 30 days, the effect of early revascularization was not significant. And the difference was exactly this one, was 8 against 7%. And actually at 6 months, it was we saw the benefit. So the point is that we need to accept that when we treat cardiogenic shock, the benefit that we get is mostly highlighted during the follow-up because of myocardial protection. Thank you for your attention. I think it has been a very nice meeting. Enjoy the rest of the meeting. Stay safe and stay strong.